thank the organizers of ISOT for giving me an opportunity to present a very interesting topic in this August audience. I'll be speaking on addressing kidney issues or CKD issues in non-kidney transplant patients. Primarily, my presentation focuses on a segment of clinicians and practitioners who are not primarily nephrologists but who are associated with transplantation of other solid organs and what is the incidence of chronic kidney disease in those segment of patients. Now, success of solid organ transplantation is one of the mysteries or remarkable achievements of modern medicine. However, this remarkable achievement of modern medicine often gets marred by one systemic complication, that is chronic kidney disease, that often complicates when patients who receive non-kidney solid organ transplantation such as liver, lungs, pancreas, heart, or for that matter stem cell transplantation as well. And the etiology can be multifactorial. Often CNI toxicity is blamed for more than its own share, but metabolic complications, infections can also be predominant risk factors. And as we dive into our presentation, we will see how early detection and a multidisciplinary management are critical to preserve graft and patient survival. A sheer look at the epidemiology and disease burden itself clarifies that even when we take a lower threshold of GFR chronic at less than 30, the prevalence of this segment of patients is 25% at 10 years of post-transplantation. And you know, the population, the CKD prevalence in general population can be 8 to 10%, but in this segment of population, it varies from 7% to as high as 21 to 22%. And it accounts for 5% of entire kidney transplantation waiting list. And it increases the mortality list up to 5%. So higher mortality is seen both in the patients of waiting list and post-transplant compared to general end-stage kidney disease patients. Across different organs, the various registry have shown, if we just look at the post-liver transplant incidence of kidney failure, the increased incidence is from 2.5-fold to up to 55 cases for 1,000 patient years. And listing for kidney transplantation in post-liver transplant, liver, post-heart transplant and post-lung transplant patient has also increased multifold over the last few years. As I just stated, these account for a significant 3 to 5% of patients in the newer kidney transplantation waiting list. So therefore, the presence of chronic kidney disease itself accounts for a strong predictor of mortality and higher healthcare utilization in patients of non-kidney solid organ transplant or NKSOT, as I will refer to from here onwards in next few slides. The Indian context, of course, in India, we have not advanced so far with other organ transplants as much as we have advanced in kidney transplantations. The data is minimum. Even then, we have seen that the incidence is 20 to 25% of CKD in liver transplant recipients and 30 to 35% in heart and lung transplants. So the challenges remain a delay in recognition and a limited nephrology involvement and, of course, lack of biomarkers. A limited nephrology involvement in patients with other solid organ transplantation continues to remain a significant challenge. There are organ-specific epidemiological indications. In liver transplantation, the prevalence can be from 15 to 30%, rising up to 50% in some degree of having some degree of renal failure. In heart transplantation, it can be 30 to 50%, 30 to 40%, 5 years. The incidence in lung transplantation, obviously, lung transplantation patients have generally a very poor ill health as compared to other organ transplantations. Their incidence can be up to 50%. In pancreas transplantation, a very interesting aspect is seen in pancreas transplantation alone. Ideally, one would expect that pancreas transplantation would alleviate the risk factors those risk factors that cause or predispose to CKD. Despite that, pancreas transplantation alone has shown a significant rise in CKD. Therefore, often we go ahead with pancreas kidney transplantations together. Hematopoietic stem cell transplantation, inherent risk is there, along with the risk from total body radiation, nephrotoxic chemotherapy, graft versus host disease, a host set of factors, including frequent episodes of sepsis or AKI during conditioning. So as I just stated, there could be different rates of prevalence in different organ transplantation. The etiology is marked by multiple factors. Pre-existing chronic kidney disease, as is often seen in this segment of populations, is one of the most significant contributing factors. Recurrence or severe AKI in the perioperative period that inevitably or inadvertently happens is another important risk factor, and chronic exposure to calcineurin inhibitors causing endothelial and vascular injury is of course another contributing factor. But as you will see down the presentation, calcineurin inhibitors are often blamed more than their share of trouble, and more importantly, we need to stress on the metabolic and hemodynamic factors or hemodynamic comorbidities. And now, as I just stated, calcineurin inhibitor remain the cornerstone of immunosuppression, not just in kidney transplantation, but across in other non-kidney solid organ transplantations as well. And if we look at the pathophysiology of nephrotoxicity with calcineurin inhibitors, then one of the important factors here is endothelial dysfunction causing ischemia, vasoconstriction, and activation of transforming growth factor beta and propirotic pathways causing arteriopathy, glomerulosclerosis, and interstitial fibrosis. And it is marked by histopathological hallmarks such as arteriolar hyalinosis, fibrosis, or glomerulosclerosis, and obliterative arteriopathy. But do we see these features in all these patients? But it is seen that despite being blamed for a large number of cases, CNI toxicity or typical histopathological features of CNI toxicity are seen in only 15% of patients of CKD who develop who develop CKD in the NKSOT population. Other traditional risk factors are very important, such as hypertension, diabetes, high blood pressure at 1 year, low GFR at 5 years. High blood pressure at 1 year can contribute to low GFR at 5 years, and traditional risk factor of poor control of diabetes and hypertension can be significantly contributing factors. A baseline hepatitis B and hepatitis C causing glomerulonephritis is an important contributing factor, despite the fact that their incidence is significantly decreasing because our ability to treat both hepatitis B and hepatitis C virus with the new as antiviral drugs. And metabolic syndrome is also an increasingly dominant etiology in this segment of patients. One more insight into the pathology: renal biopsy findings can vary from organ to organ transplantation. In patients with liver transplantation, the predominant cause of chronic kidney disease or the predominant finding done in histopathology in the kidneys is IgA nephropathy, MPG or nephrophages. In heart and lung transplantation, however, there is arteriolar hyalinosis or interstitial fibrosis, and only 15% have CNI related lesions. Now, if the kidney starts spilling protein into the urine, proteinuria more than 1 gram per day, or a rapid decline in GFR, they often correlate with active glomerular lesion on the biopsy. The pathologic interpretations, as I just stated, is a combination of factors: chronic hemodynamic stress, drug toxicity, and metabolic injury. Heart and lung recipients have vascular interstitial lesions predominantly because of the underlying pathology, and liver recipients, as we are often aware, are associated with immune complex glomerulopathies. So this highlights the need for a routine nephrology pathology collaboration in transplant follow-up. Once again, GFR. Now, creatinine itself is not enough, so we have to go ahead with different GFR estimation strategies. Why it is so important? Because most of these patients are cachectic, they have got chronic sarcopenia, so there is a loss of muscle mass. So often, these GFR equations have a tendency to overestimate the GFR. So the studies have shown that CKD EPI equation is preferred over MDRD equation in estimating GFR, and also we have to understand that cystatin C based equations give a good accuracy, and serial monitoring is also important. The KDIGO also stresses that when we have these risk factors present, and when especially the UAE or urine albumin excretion rate is more than 30, then achieve a target of blood pressure less than 40. And if there are other comorbidities present, then one must add ACE inhibitors, ARBs or SGLT2 inhibitors as and when required, and refer to a nephrologist when there is AKI or sustained drop in GFR, or your GFR is less than 30 or urine albumin excretion rate is more than 300. These may be the points I am repeatedly repeating, but it is important because many of the patients, many of the practitioners of non-kidney solid organ transplantations are not very keen on referring to the patient to a nephrologist till a late stage. So as I just stated, BP control, adding ACE inhibitors, ARBs, low sodium diet, and minimizing nephrotoxins. Other nephrotoxic antibiotics have to be also minimized. And Now, the rationale for immunosuppression optimization. Since CNI is blamed more than its share, often there is a tendency to stop CNI altogether. But the strategies or the studies have shown that instead of stopping CNI minimization can give a significant improvement in overall outcome. And sometimes CNI minimization, when combined with mTOR, can give acceptable or better GFR with acceptable rejection rates. Because CNI withdrawal can increase the rejection rate, so CNI withdrawal is discouraged and CNI minimization is to be encouraged. And CNI minimization along with institution of MMF where appropriate. mTOR use has not been very encouraging because it's risk with proteinuria and delayed wound healing. So mTOR only has limited indications. And as I just stated, mTOR has a limited indication because of its adverse effects like proteinuria, dyslipidemia, and impaired wound healing. However, the optimal candidates are those with early decline but a preserved structure. Long-term survival are similar to CNI-based regimens when they are introduced judiciously. MMF and belatacept. MMF we know is a very good armamentarium element in our armamentarium. It allows further CNI reduction as in CKD patients with kidney transplants, and its adverse effects are acceptable. Often cytopenias have to be taken carefully. Belatacept, which is a co-stimulation blockade, doesn't offer very significant practical advantages despite its theoretical or perceived benefits, so it's not so much approved in patients with NKSOT. And future directions always targeted a combined protocol to replace or delay CNI exposure entirely. Now look at the role of kidney transplantation after NKSOT. Now, even in this segment of population, kidney transplantation offers significant benefits because the mortality rate drops by 50%, quality of life and functional independence improve, and graft and survival patients, though they remain lower than primary kidney transplantation patients, despite that the transplantation after non-kidney solid organ transplantation offers survival benefits as compared to those patients who do not get a kidney transplantation. Now, even in the elderly segment of population, kidney transplantation after NKSOT also gives survival benefits. So how do we, in my final few slides, I will take you through how we go for early identification and risk prediction. Early risk identification or stratification is very important. Liver transplant specific risk models have to be designed and allocation models have to be designed accordingly. Pre-transplant biopsy often identifies occult glomerular disease affecting allocation decisions, and a surveillance focus on post-transplant proteinuria, blood pressure trajectory, and CNI trough variability have to be looked into. And kidney biopsy, a low threshold for kidney biopsy, if there is proteinuria, GFR has to be instituted, biomarkers have to be judiciously used, and interventions to preserve kidney function have to be strategized. Now, key label principles are: prevent first hit, avoid perioperative AKI, limit chronic nephrotoxic exposure, treat modifiable cardiometabolic risk factors, use nephroprotective pharmacotherapy early. So the take-home points are: CKD after non-kidney organ transplantation is common, up to 20%. The main drivers are peri-transplant AKI, metabolic risk, hypertension, prolonged CNI exposure. Only 15% of cases show CNI nephropathy on biopsy. Early nephrology involvement is very important. Immunosuppression adjustment, CNI minimization, and mTOR where appropriate has to be instituted, and policy shifts have to be designed accordingly. That's all for now. Thank you for a patient listening. Thank you very much.